We are the Marie Curie Palliative Care Research Department's methodology team. We support members of the research team from the beginning of the project, when it's in the design stage, to the end of the study to ensure that the interpretation of the research is correct. We ensure that the research is rigorous and correct methods are used, and thereby ensuring that the results are meaningful. We also conduct our own research within our dedicated fields, and which we'll give you a flavour of in a moment.
In palliative care, there are, as in any area, challenges in undertaking research. In palliative care, there are difficulties in recruitment and in retaining patients in research studies. Multiple outcomes are often assessed, for instance, because it can be unclear what outcomes a treatment or therapy has an impact on. There may be lack of clarity on what impact should be expected in the research. For example, should a treatment stabilise or improve? Patients also vary, such as in age, in disease stage, treatments, and type of disease. All these issues may be difficult to analyse or to conduct research data.
As a health economist, the focus of my research is on evaluating an intervention in terms of both costs involved and benefits accrued. In palliative care, there are a number of distinct research challenges in health economic evaluation. On the cost side, interventions are often complex, and patients commonly have a range of illnesses and needs, are frail or can have cognitive impairment. They transition through multiple care settings and at times are not able to accurately recall their use of health services in the previous weeks or months. Hence, capturing all activities and assigning accurate costs can be a challenge. Where possible, we try to capture the significant inputs provided by family carers or friends of the patients, as their contribution is generally omitted in a standard health economic evaluation, which focuses on a payer or health service alone perspective, rather than on a society as a whole. On the benefit side, health economics concentrates on improvements in the quality of life. It is common that benefits of palliative care do not produce high gains within the standard evaluation framework, partially because the goal is not to extend life, but to improve the quality of life remaining, and certain domains like spiritual or psychosocial are not included. Focus is on health alone and on the patient, not capturing the benefits of palliative care provision to informal caregivers.
I'm a medical statistician and I work across numerous different clinical studies, including clinical trials and cohort studies. I have a particular interest in analysing clinical trials. A clinical trial is the most rigorous way to answer a question about the effect and safety of a new treatment. Trials often involve two treatment groups, with one group receiving a new treatment and the other group receiving a control treatment. To measure the effect of the new treatment, an outcome measure needs to be recorded to examine the difference in impact of the treatments, if any, between the two treatment groups. My research focuses on the use of multiple outcome measures in clinical trials. Multiple outcome measures can be beneficial as they enable clinicians to investigate many aspects of the disease being studied. However, several statistical issues arise when analysing multiple outcomes. We performed a review which showed that multiple outcome measures are often used in clinical trials, but often the analysis is inadequate. I am now investigating which statistical method is the most appropriate to use when analysing multiple outcomes in clinical trials.
One of the aims of Marie Curie Palliative Care Organization is to broaden the cohort of potential beneficiaries of the services. Currently, while end-of-life services are more routinely provided to cancer patients, it's difficult to provide similar services to patients affected by a number of other conditions, such as chronic obstructive pulmonary disease, COPD for short. I'm a statistician and I'm working in a study targeting patients affected by COPD, which is a major cause of mortality in the UK. Patients with advanced disease often have a poor quality of life, but uptake and use of palliative care in patients with advanced COPD is low, mainly due to the difficulties in predicting disease progression. Statistics and the use of UK electronic primary care healthcare records can be effective tools to tackle this issue. Using thousands of records, we are currently working on the development of a statistical model for assessing the risk of death in a cohort of patients diagnosed with COPD. Our aim is to find those factors which can meaningfully be used to predict one-year mortality, so that physicians can rely on an instrument that, using routinely collected non-specialist information and easily available primary care data, could help identify more COPD patients seen in primary care that may benefit from palliative care.
I'm a systematic reviewer with expertise in pooling and analysing together similar and also mixed types of studies. What I mean by mixed here is reviewing both trials that test a drug or a non-drug with studies that explore patients' views or needs related to their care. I've worked in the department since 2007 and are now a co-author of over 30 reviews in palliative care. Reviews are important to healthcare, including palliative care. For instance, most conclusions about treatments, including recommendations and clinical guidelines, are based on systematic reviews, not single studies. Reviews also enable us to take stock and see the deficiencies not only in what is known about a topic, but also in research conducted in a topic. For instance, new research undertaken to help inform best practice can only build on learning from earlier research if this research has been fully reported. Thereby, by taking stock of available published evidence, a review can highlight weaknesses, and we hope in doing so our reviews in the department will have improved future research. Our reviews within the department have also helped direct more appropriately where there is both a public and clinical need research funding for both Marie Curie and other organisations such as the UK National Institute of Health Research.